I don't want to take a half hour talking about this. I want to have people to have an opportunity to make comments and see if there's anything that I can answer. I'll tell you, there's a lot of things I can't answer. This is a very confusing field. It's moving very quickly, and it's replete with publications. I mean, there's just thousands and thousands of publications. It's hard to keep up with this stuff. But this section is sort of complementary to the talk that we had earlier. We're talking about low-risk coronary artery. We're talking about a low-risk group for acute coronary syndromes. Most of the studies in this section, the papers that are here for the most part, they're looking at these various provocative tests or risk stratification tests and comparing them versus a gold standard of angiography. So we've already discussed how that might not be the ultimate gold standard, but it's a pretty good standard. I mean, angiography is pretty good. There's a couple of things that I would point out to you in this section. You'll see that Mel has written down a reference for an article by Judd Hollander. It's an editorial there. If you could circle that and pull that and print it out and read it, I think it's only a couple of pages long. Judd Hollander is one of our colleagues. He's actually the current president of the Society of Academic Emergency Medicine. He's out at UPenn, and he does a lot of cardiac research, a lot of good stuff. And his article basically are all the bells and whistles necessary, the things that we're doing to people when we put them into our low-risk chest pain stratification protocols and chest pain units. I want you to add another article to that. I'm going to get you the reference for it. It's by a gentleman named Grant Innes. And Dr. Innes is up at St. Paul's Hospital in Vancouver, Canada. And that's Innes is I-N-N-E-S. First name is Grant. And that editorial is called Field of Dreams. And it's in the Canadian Journal of Emergency Medicine. You can just get that online for free. It was October 1999, page 159, Field of Dreams. And the reason that I want to point those two papers, one is American and one is Canadian, but they really get at the same issue, which is the issue of when we increase sensitivity, there's an inevitable drop in specificity. Another way of saying that is, if we've already gotten these patients down to a very low-risk group, using our history physical examination, our increased awareness of all the things we've learned over the past 20 years, how people often present with GI complaints, all the things that used to trick us that no longer do. We're a lot more hypervigilant about acute coronary syndromes. And we do that stratification. We do an EKG. We all are doing, I think at this point, serial EKGs. We're not falling into that trap. Our improved markers that we have. At the end of the day, we're pretty good. And when we put these people in the chest pain units, say we're already at a sensitivity, where, like our miss rate is 2 or 3%, so our sensitivity might be 97%, for example. If we try to get our sensitivity up to 99%, okay, there's a requisite drop in our specificity. Patients might go through the chest pain unit, and it may be true that we pick up a few more people on, say, an exercise treadmill or something like that, but at what cost? And in those two papers, Judd Hollander and Grant Innes both point out that the cost is enormous, and the cost is really one of false positives. You're putting all these people that you really don't think have coronary disease, or at least an acute coronary syndrome, and on the treadmill, and you're picking up a whole bunch of positives. They either can't complete it, they have some changes in their ST segments, they have some pain that you think might be similar to the pain they produced with, that they came with, and those people go on to have a battery of unnecessary tests, and sometimes unnecessary interventions, including stents and other things, which may in turn even be harmful. And so really, the question is, what are we really doing here? Who are really helping? And in that, I actually wrote down the table. I was going to give you some of the numbers, but it's probably not the best thing to sort of give. It's probably better if you look at it yourselves. But Grant Innes writes a very simple 2x2 table where he says sensitivity 99%, specificity even if it was 95%, even if we had pretty good tests that usually were very specific, he writes out what the numbers are, and it shows you that basically the chest pain units are false positive generation machines, and they really aren't necessarily going to be of any use. What happened, just to take a step back, was that we had a wonderful thing in CCUs. CCUs were a real big step forward in the 1970s, 1980s. People that were dying of arrhythmic deaths, people that were having early heart failure, we did them some good by having them in CCUs. But then we just applied the same model to patients with a much, much different risk profile with low risk, and we just sort of superimposed it on top of them. And I think that's what the issue was. And so things like, even I think Diane mentioned the other day, monitoring patients. Why monitor a patient who has already stratified down to such a low risk of cardiac disease? What is the utility of that? Has anyone examined that? And of course, when people have started to examine some of these things, they found out the emperor has no clothes, so to speak, and that maybe these things aren't the best things to do. So I think you should read those two very quick papers. I think those are very, very clear, well-written, very eloquent, much more eloquent than myself in explaining that problem. And basically, the upshot of it is hey, listen, if we're going to do these things, let's examine them critically and see if we're really getting what we think we're getting. Are we really getting our bang for our buck? Are we really helping people? The remainder of the chapter and the abstracts there focus on the different tools that are used for risk stratification. The first one is exercise EKG. How many here use exercise EKG as part of their protocol in their department? Only a couple of people? No? Okay, how many people refer out and they find their patients are getting exercise EKGs as a frequent? So it's probably about a third. How many people are using more advanced studies like nuclear medicine studies or stress echo as a routine thing? Okay, so that's probably about another third. These are things that you know a lot about. If you use them in your center, you probably know a lot about it. If you don't use it, you might not be as familiar about it. And the purpose of this chapter, is, as Mel Herbert also wrote this one, is just to describe the different tests and to say what they are as an informational thing, and then to make some general comments about all the tests together. The one that's a little bit different than the rest is exercise EKG. The reason being is it's clearly not as good as the rest. Exercise EKG is relatively easy and it's available, and that's why I think that it's so common still. Just a couple of facts about it. It's positive when pain is reproduced. It's similar to the pain that they came in with. When they have ST segment depression of 1 millimeter or more, especially if it's downsloping or flat. Also, an important thing to recognize about it is low blood pressure. If your blood pressure goes down when you're exercising, what does that mean? That usually means that's a really bad thing. That usually means a problem in the left main. So that's an ominous sign. Next to them collapsing in VFib, the second worst thing that can happen to someone on a treadmill is if their blood pressure goes down, because your blood pressure should go up when you're exercising. Your heart rate and your blood pressure both go up. If your blood pressure goes down, just be aware that's an emergency. That's get the paddles on, put the patient on the gurney, get them to your critical resuscitation area. And I know I point that out because some people aren't familiar with it. They don't do that. That's something that you really got to be concerned about. You can't do, obviously, exercise EKGs on patients that have EKGs that are all screwy to begin with. They've got a left bundle, they've already got ST segment depressions, that's not going to work, right? So there's a whole bunch of people that can't do it. Obviously, you can't do it if you've got arthritic knees. These are all things that are fairly straightforward. But the problem with exercise EKGs, abstracts 1 and 2 both talk about them, is that they're just not nearly as good. They're not as sensitive or specific for coronary artery disease as all the other things that are discussed in the chapter, all the other specialized tests. Mel quotes some figures here that seem a little bit different than some of the numbers that I've seen over the years. He quotes a sensitivity of 50% and a specificity of 90%. I haven't really seen numbers that high for specificity in most of the studies, and I think it's also important to recognize that if you don't select patients properly, you get into trouble. You've probably heard about this. First off, women. Women don't seem to the results of treadmill tests on women seem to be so much different than men and so inaccurate that many cardiologists have recommended not using it for women. So that's something we all need to be aware of. It might not be the best test for women. The other thing is that if you pick people that are too high risk, or too low risk, you get poor numbers as well. If you take a patient who you really essentially, a 30-year-old comes in with a twitching in his or her chest, and you're just like, that's not cardiac, and it's lasting for seconds or something like that. The story is off. They don't have risk factors. You really don't think it is. And you put them on a treadmill. The chance of you getting, if you get a positive result, the chance of that positive being a real positive is minuscule compared to the chance that it's going to be a garbage false positive, okay? So you really have to be careful that you don't put people that are too low risk or too high risk on it. In particular, the treadmill seems to be very sensitive, when I say the word sensitive, I don't mean it in the same way as sensitive specific. The treadmill seems to be very sensitive to its patient selection, and it's a real pitfall in the treadmill. For a lot of those reasons that I've mentioned, people have given up. You can't use it with some people. The selection's important. It's not, the numbers aren't great. That's the reason why a lot of you guys aren't using it anymore in your centers. There's a bit of a philosophical issue here. If it's cheap and it's available, I know in the county system, both Diane and Mo and I, we are all using treadmill, and we use it right in our department. We have our residents administering the treadmills, and they learn about it and they learn how to supervise it because that's what we got. We're not a resource-rich environment. We can't get nuclear studies and stuff very easily. So is it worth doing it? And it's a bit of a philosophical thing. The fact of the matter is from a medical legal perspective, it is protective for you. It is. Even though we know there's a lot of pitfalls with this test, if you have a patient that has a bad outcome and you went through the trouble to get a treadmill test and you made those arrangements, it's going to protect you somewhat in court. It's still considered a standard practice. Abstract number 3 is a pretty good one. I don't think it necessarily is something you need to pull unless you're particularly interested in this stuff, but it's a good review article that talks about, it's not a review article, sorry, it's a good article that compares different modalities. And abstracts 4 and 6 deal with nuclear imaging. Nuclear imaging, basically, I think for most of us, is sestimib. That's the most common agent used, I think, in the United States now. It's a very good one. Basically looks for perfusion deficits, and it's basically an analog of an electrolyte that's taken up by myocytes, and when there's poor cardiac perfusion, it's not taken up as well. Sometimes when you read those studies, you're not sure when there's poor uptake if that's just dead old heart muscle or if it's myocardium that's hibernating, that's at risk, and that's something that you have to distinguish. And that's why an exercise study or a provocative study or a stress study where you're actually provoking the heart muscle gives you more reliable information. So being able to compare a resting versus a stress version, so before and after exercise or before or after an agent that's going to stress your heart out like adenosine or percentin that's going to make it work harder, gives you more valuable information on what's dead and what's at risk. And so for all the nuclear imaging studies and for the SPECT study, which is actually just a version of doing the same type of thing but using CT and getting three-dimensional images, which is a little bit better than the nuclear imaging studies, and for echo, which also looks which also is a helpful test. It looks at wall motion abnormality. For all three of those, doing them with stress, either by exercise or by giving a drug that stresses the heart, is a more useful thing and increases the sensitivity and specificity of them. So some people use nuclear imaging studies. Some people use where you see those sort of grainy pictures that you get, like on a VQ scan, those types of images, which are reasonable. But the SPECT, which gives you colored CT images, that the single photon emission CT, you're also injecting a radionuclide that's taken up by the heart cells. But in this case, you're doing a CT, and you get a color-coded version of what in the heart is taking up the substance and what isn't. Those things. Those tests are all very similar in terms of what they do to minimize to reduce your risk, to pick up some more patients that you wouldn't have picked up with your normal history, physical, EKG, and markers. Just to throw out some numbers, and these are all over the board, they're generally about 90% specific, 90% sensitive for acute coronary syndrome, and specificities are usually in the 70 to 80% range. But you'll see a big variation. I don't think that, aside from the exercise EKG, and we definitely should put that on a lower tier because it really does have a lot of pitfalls. Whether you're using echo, dobutamine echo, whether you're using SPECT scans, whether you're using nuclear medicine tests at your hospital, forget about it. Just don't worry about it. The differences between these as tools for risk stratification are probably negligible. Because remember, we're talking about a group of patients that has a very low risk to begin with, and you're talking about fractions of percentages of differences between these. All of them have the same pitfalls, that they're not perfect, that they do miss a few, and all of them have the same pitfalls, that they pick up people as false positives that have unnecessary testing done down the road that they didn't really need. They're all in that boat. Okay, so I don't think it's better. It's better to just really know it's more important what's available at your hospital, what can you use, and then go with that. And then develop a protocol in your hospital together with your cardiologist so that you guys have a system. I think that Diane mentioned this yesterday, but it's very helpful to protect yourself medical legally to have a policy and a system at your hospital. You know, to be able to point to whatever it is. I mean, it could be something that's very elaborate, that has SPECT scanning, if that's available, and you can set that up with your radiology department, or it may be something very simple, like a modified TIMI scale, where you're getting outpatient treadmills on some patients. But whatever it is, if it's something that you can point to that says, hey, this is what we do. The doctor makes a clinical judgment about what risk category the person is in based on some objective criteria, maybe some that are subjective, but at least some that are objective. And we put the patient through some sort of a protocol. And if you make a mistake, you're allowed to make a mistake. Remember, medical malpractice, it's not against the, it's not illegal, and it's not against, it's not necessarily malpractice to make a mistake. Especially if that mistake is made within the context of a systematic thing that all the other doctors in your department are using. There's a lot of different models. There's a Cincinnati model. There's what they do at Virginia, Commonwealth. There's all kinds of different things that you can look at. But I think that if you don't have something like this, there's something, you know, that we have something at our place that's very well established. We have a CPU and a protocol. Diane at UCLA, they don't have a protocol, but they follow, or they don't have a CPU, but they have a protocol. This is really helpful. It will help to you can't be perfect at this game, but it really will reduce the stress somewhat if you can document on your chart that I assessed the patient according to our chest pain stratification protocol, and you know I made you know, after looking at the variables, my conclusions they were moderate risk, and this is what I did. That is really helpful to you, and even if you've made a mistake, I think you'll find that that's going to be pretty bulletproof in a lot of cases. What else? There's a few articles there at the end that's kind of interesting on contrast-enhanced echo. Has anyone using contrast-enhanced echo at their place? It's kind of a newfangled thing. It's really neat. They inject these little micro bubbles into your venous circulation of inert gases, and they show up on echo. They're echo opaque, echo lucent. They're echo show up. And you inject them, and they're small enough that they actually get through the pulmonary beds. They're very tiny bubbles, and they show up. And they show you, not only do they show up the walls of the heart, the pictures are really neat. Because you ever wondered when you're looking at the echo techs or the cardiologist doing an echo and they're saying, oh, he's got pretty good wall motion there and not very good there, and you're like, that's kind of hard to tell, you know, how do you tell? If you put those bubbles in, it really shows up. It shows up the wall motion, and you can really see how each wall is moving a lot better. And not only that, but because it goes into the microcirculation of the heart, it actually shows you what's being perfused and what's not being perfused. So it shows you both wall motion and better and perfusion. We're just pointing it out because it's neat, and it looks like it's pretty good. Even with the resting images, it looks like it has a pretty good sensitivity and specificity for acute coronary syndrome. And it might be another tool in the armamentarium that's a lot more convenient than shifting someone off to get a radionuclide. And or to CT scan, and of course it doesn't have the radiation risk of those. So that's just something to, you know, just keep your eyes out for it, keep your ears to the ground, and that might be helpful. That's what papers 9 and 10 are about. So that's really. Let me stop there and see if there's any questions. I think just maybe the take-home point would be just to remind, you know, just to reiterate, common disease. You're going to miss some. Have a system. Have a system, discuss it with your colleagues if you don't have a system, discuss it with your cardiologist. It's going to protect all of you. That's the way to deal with this. Any comments or questions? Wisdom?